Mm. All right, welcome everyone. Let me continue to admit folks and then we'll get started. All
Ti-
right.
You
Go
good,
ahead.
Tiffany?
Yep.
Sorry.
Good afternoon, everyone, and welcome to our January Learning Forum for KPQC. Please enter your name and agency in the chat as we continue to admit folks. I will turn it over to Carrie and Tara to get us started.
Hi, guys. Happy New Year. It is almost February, but I don't know how your day is going. It feels like it's a little bit of 2026 all of a sudden, too. We are glad that you're here. We certainly are thrilled to share information about our new safety bundle launch. And that will be the second half of our presentation today, if not a little bit more. But the buzz is real, and we're thrilled to get going. Before we do that, we have for many years now have done what we call rapid response, which is both show and tell, as well as important data that comes out kind of rapid fire or rapid response wise, so that we can get information across the state. Many of you, us, were hit by a small snowfall a few weeks ago. Now I've actually called Snowmageddon 2025. I was paying attention to the healthcare providers in this moment for obvious reasons, and saw many, many of you working extra shifts, sleeping at the hospital, doing extra things for your patients that would have been outside the box of normal. And I watched some pretty impressive things specific to maternal and infant health happening to get patients to your facilities. I grabbed one that I love the smiles. And so I grabbed the picture. This is Lawrence Memorial. Congratulations to you guys for doing what many, many people did across the state, and applauding your staff for their work. In the middle there is a picture of basically a carpool, because we couldn't get anywhere, right, guys? And so we grabbed each other, said we're going in together, buckle up, and sure enough, they went in for their shift. Also, Lawrence deserves a huge high five. Those guys, like several other hospitals, have gotten huge accolades, which we'll talk about some more in a minute. But they were recognized for high quality maternal care, specifically with the Blue Distinction Center recognition. Congratulations to you all. Next slide. So again, in the middle of a Snowmageddon, many of you are submitting QI projects as part of FTI or beyond that, that are and getting recognition for all of your hard work. Amberwell Hiawatha has long-term been a highly functioning facility. Chelsea James has been on leadership with this community of the KPQC for lots of years, and they recently were recognized as Maternity Care Access Hospital. This is a conversation about OB deserts and high level care of obstetrics and neonatology, meaning pediatric care, in a place that potentially is identified without good access. We know that Amberwell Hiawatha has been providing high level care for lots of years, and wonderful that they got that designation. Next slide. And one more to talk about. And also, if you all that are listening on this call have things to share and show and tell about, send them to Carrie or I. And we are so thrilled to both share that information at the state level to the folks at the big tables, and or to tell each other some of these great things that are happening across the state. Stormont, Topeka, recently officially designated as a teen birth hospital. You guys, we heard lots and lots about this teen birth designation as they were finishing it up, and it will continue, but doing some major project and analysis around the teen birth approach. Phenomenal work. And sure enough, they got the designation, which is really wonderful. And you'll see on that second bullet point, one of the biggest things that Stormont Topeka noted as part of their teen birth approach, which is a significant decline in the number of C-sections amongst their primiparous patients, and believe that team meetings are part of that story. So kudos to you all and to all the facilities doing really important work across the state. Next slide. Uh, uh, this is the Tara Schroeder January moment. You have been through this with me for probably 3-4 years now. The nerd in me has to see what's happening because I want to make sure that we're following the data and not guessing at what's happening to our patients, and why we look to reports to really validate or to not validate our efforts on the KPQC. The 2023 KDHE Vital Statistics Annual Report, we've walked through that in years past. It provides state level data. It also provides county specific and regional data about lots of things, to include maternal and infant health. And I just grabbed some screenshots of that report. That link is right there, and Carrie or Tiffany or whoever wants to put that in the chat so you can link to it and take a look at it. I think you'll find it fascinating. On the left-hand side, that box, I pulled it out specifically because it's always interesting to me to say what that every day in Kansas, ... So every day in Kansas, there are 93 live births. Some days it feels like there's a 9,003, but 93 live births, how many deaths, etc. And it talks about, of course, on the live birth rate, live births, low birth weight, infant deaths, etc. The delivery method, I think this is important for us to keep on our radar. They check it year to year. They also do 5 to 10 year increments, and the vaginal delivery rate versus primary cesarean rates are in that report. Again, I grabbed out some snapshots of that information. And then on the right-hand side, infant death rates for racial demographics, actually. So white, non-Hispanic, Black, non-Hispanic, and Hispanic are all compared orange, gray, blue there. And unfortunately, you see some significant disparities there. It's also fascinating to look at the continuum. You see the numbers overall from 2004 to 2022, 23 going down, but notice the roller coaster ride. And that's not what we want to see. So we have included our pediatric partners in our new bundle on purpose, and we look forward to increasing our pediatric quality improvement in years to come. Next slide. So this is one final beg. I'm begging. If you are a 4-trimester enrolled facility and have not sent me your birth numbers for 2024, please do so. I need aggregate numbers is fine. Send them to me on an email. If you have questions or concerns about that, reach out right away. Folks, that helps us tie up the final data entry into our previous bundle. We need to do that so that we can move all of our attention into our new safety bundle while also continuing the work of FTI. Lots of things ongoing, but need the birth numbers ASAP, please. So just send them to me an email. Reach out if you have questions. Next slide. So how does 4th trimester continue the work while we go into a new safety bundle? Next slide. You guys may remember, those of you that are that have been around a while, or if you're new, I want you to hear the words that our our maternal mortality and morbidity data was pretty clear that postpartum, the postpartum period is where we needed to start our efforts. And we knew that from the moment of birth through the first year postpartum, that entire continuum really needed overhauled. And so we created this mission statement. And in fact, the overarching goal is to create a better Kansas, make it the best place to birth, be born, and to raise a family. Next slide. So through the 4th trimester initiative, we really dug deeper into the data. This is, again, items you've seen before. I'm reminding you because as we move into the new bundle, you need to understand how the data does matter. We thought seatbelts and seatbelt use was in fact the problem with maternal mortality reports in Kansas. And then we opened the Pandora's box of the truth. Mental health conditions and substance abuse disorder were in fact the bigger story, and why perhaps the accidents occurred with those women who passed. We also dug deeper into heart disease, suicide, and unintentional injury reports, and found that we needed to really talk about mental health in the postpartum period, access to care, and how we treat, evaluate, refer. Next slide. We connected ourselves at the state level to the national bundle AIM, which you've heard us talk about now for a while. the postpartum discharge transition bundle, which connected directly to our 4th trimester initiative in Kansas. We aligned ourselves with best practice models, reported our information, which is what we continue to do, back up the national chain, and connected with folks that were doing similar work. Next slide. And we created what we all should be really, really proud of, which is this new postpartum model of care. Kansas should never go backwards. It should now always be assumed, and we will continue the work indefinitely to follow this care model. You've seen it, you've embedded it. Carrie will talk to the data of that here in just a minute, but it should never happen again that a patient delivers and does not receive access, referral, and follow-up to whatever it is that that patient needs. And so this model now, you will see it look very similar to what we're creating with our severe hypertension bundle. And we're thrilled for those of you that have fully embedded this model. The next model will just fit right in. Next slide. I'm going to turn it over to Carrie, but one final thank you on my part to those of you that have been a part or just recently joined the 1st trimester. We're excited to work with you in the future. This great state that you're looking at a picture of is hard work that's happening on behalf of all families in our state, no matter the outcome. And I appreciate your efforts. We're going to keep working hard. Carrie, take it from here, hon.
Sarah, can you hear me okay? Okay, good deal. Back on the slide that we were on just before that, I just wanted everyone to take a minute and look at all of the facilities that were enrolled. We're going to celebrate that as well as I look forward to seeing that plus some more stars as we enroll in our next bundle here. Next slide, please. So we compiled all the final data that we got from all of our facilities back in October and just try to get a glimpse at where we started and where we ended, and looked at all of our metrics that we were measuring. So when you think about the post-birth warning signs education, not only educating your staff, but ensuring that that process is embedded in every discharge that happens at your facility, we're excited to say that 83% of our facilities have fully implemented that component. Next slide, please. In regards to having a comprehensive postpartum care team, we're celebrating that 86% of you guys have fully implemented this. That does not mean that there's not more in the works, and we anticipate that that will continue on, like Tara mentioned earlier. Next slide. Having that postpartum appointment scheduled for that patient prior to discharge, 81% of facilities have fully implemented that. That's amazing, you guys, amazing. And we know and acknowledge that some of that is outside of our control. So we just encourage that we keep looking at how we can improve upon that and embed that process, especially as we move forward with our hypertension bundle, knowing that that will also be a component of that bundle as well. Next slide. The postpartum visit template. So really that comprehensive template to allow your providers to get a picture of what happened during her stay so that they can carry that on into that 4th trimester. Our goal was that every site share out with all their clinics and agencies that will be seeing the postpartum patients. 73% of our facilities have fully implemented this or in the process of implementing that. So way to go, Kansas. Next slide. We look at birth equity training and our patient debriefs, especially because we kind of consolidated those pieces as we went further with utilizing Mama's Voices to integrate some of that birth equity training and the importance of patient event debriefs. And 81% of our facilities overall have fully implemented that. That's huge, 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 huge. Next slide. Asking the question in the emergency department, have you been pregnant or delivered a baby within the last year? Every patient, 76% of facilities have that are enrolled have implemented or in the process of implementing this. That's going to become imperative too as we roll out this next bundle in order for our emergency departments to be able to identify how truly abnormal those unalarming blood pressures are that they're used to seeing in order to treat it in a timely manner. So way to go. Next slide. Our SSVOH, that's structural and social determinants of health, 73% of our facilities enrolled are screening or in the process of implementing that screening at their facilities. Next slide. The intimate partner violence. Not only are we screening, but making sure that our staff have received the education on signs to look for, and how do we get those patients the services and the safety net that they need. 74% of our facilities enrolled have either fully implemented or in the process of doing that. That is also something that needs to be continued on as we move forward in our bundle too. So great job. Next slide. Breastfeeding. When we look at how many of our facilities enrolled are either baby-friendly designated or high five designated, 75% of our facilities are either one of those. And then we have another 8% of our facilities that are in the process of obtaining one of those designations. So great job out there, especially when we roll into this next bundle. There's that neonatal component, which is ensuring that all of our moms are pumping within a timely period after delivery if they have a baby going into the NICU or transferred out of that facility. And we'll talk more about that. Next slide, please. This looks like a really heavy slide, and it is. We're not going to read through all of this data, but really what we want to highlight here is the amount of effort being done within the state for maternal mental health. 73% of our sites have depression screening in place, 68% have anxiety screening in place. And again, this slide deck will be disseminated out to everyone, so that will afford you the opportunity to be able to read through this in further detail. But a lot of work has been done within the state regarding maternal mental health, and there's more to come. Next slide, please. And then we've updated, because you guys continued to do all the great work, we went ahead and updated the facility recognition criteria. So just a reminder, if you had 0 to 3 of the initiatives fully completed, you're a bronze level, 4 to 6 fully completed, silver, and 7 to 9 initiatives fully completed, you are at a gold status. And we really focused on the 9 primary AIM bundles when it came to how we allocated those designations. So if we'll go to the next slide, you'll see our bronze throughout the state. So congratulations to those facilities for achieving the bronze level. Next slide. An exciting increase in those who are the silver level. Great job, everyone. And then next slide, please. I want you guys just to see that. That's huge to think how many of the enrolled facilities in Kansas have fully implemented at least 7 to 9 of those measures that we are looking at. That is amazing. So great job to everyone for all the hard work. And we fully expect to see all of those facilities enrolled in our next bundle, and we will continue on from there. So next slide, please. And speaking of that next bundle, I'm going to pass it back to Tara, and she's going to talk more about that.
Jill has figured out how to do some cool stuff on Zoom. I'm like, is that pigs flying? But it was not. It was pigs have not flown yet. Hey guys, let's talk now. Congratulations, everybody. I was completely distracted by a squirrel called Fun Emojis. But we are thrilled to talk about the severe hypertensive bundle and relevance to the work that we saw from 4th trimester. Been involved from day one, going back to the NAS initiative, but also to remind some of you that the NAS, or for those of you that are new, that the NAS created a red flag to us that we needed to focus on 4th trimester work and maternal mental health, because the NAS initiative, sure enough, the data flowed and told us that's true. We did 4th trimester because we believed that to be the most important process improvement, and then said, hold on a second, we see some specific data coming out about preeclampsia and specific to Kansas. And sure enough, it's a growing problem. So every bundle is red flagging us to the next thing to do, while we're also receiving data almost constantly that tells us yes or no or add to it. So when we decided to do the severe hypertensive bundle, it was because we knew it had been a problem in Kansas, certainly across the nation. But sure enough, the prevalence of preeclampsia diagnoses in our state increased. And so this is just a to me, it's a fun graphic looking from 2016 to 2023. And at the bottom in bold, in Kansas, this is specific for our state, the prevalence of preeclampsia increased from 4.8 in 2016 to 6.9, statistically significant. Next slide. This is Kansas Hospital discharge data. So if you open the layers and begin to say, okay, we know that there's a problem. If we're talking about preeclampsia and all the associated severe hypertensive events, sequelae, or disorders, then let's dig deeper. And bottom line is that we see significant health disparities and racial disparities amongst those who experience some of the hypertensive disorders. For example, if you look, and age-related, not surprising to many of us, our higher rates in the maternal age groups for preeclampsia-related diagnoses are the 45 to 55-year age group with prevalence of 11.6%. Lowest in our, let's see, my eyeballs are big enough, 30 to 34. And certainly, again, on the extreme, we knew this, the extreme ages. So 12 to 19 is 8.5. And again, at the upper end of the 45 to 55 being your highest. So age related, we knew this, but in Kansas, it holds true. Our extreme ages, in fact, look like they're highest prevalence. And then if we ask ourselves, okay, is there a difference in terms of race and ethnicity? That second group of folks that you notice there, unfortunately, we see once again that our Black and African American Kansas residents have higher prevalence for sure, preeclampsia related disorders, followed by American Indian and Alaskan Native. We've known that those two groups, as well as our Hispanic group at 6.7%. So those three in the top three, again, in terms of those folks that we need to pay attention to, their rates are higher and we need to know why. Payer class, we typically have talked about that Medicaid, we find rates higher in our Medicaid population. Again, the question that we need to make sure is what we've heard, is that correct? The answer is yes. The hospital discharge data is consistent with that information. Our Medicaid patients have a higher prevalence than our private pay patients, as well as self-pay. So next slide. With that information in mind, and we say, yep, we saw a problem that showed up in for trimester work with preeclampsia being higher, access to care, treatment, follow-up postpartum with our hypertensive disorder patients. Let's pull in the severe hypertension bundle. Let's look at Kansas data. Yep, sure enough, here's the groups that we need to figure out. We're even, you guys, looking at regions of Kansas and higher prevalence in certain regions of our state. This is valuable information, but it doesn't mean that not everybody gets the content. And you know that our belief from day one with this QI work has been that everybody across the state deserves the best care. And so everyone is part of the initiative. Specific to the severe hypertension model, then, if we target certain demographics and age groups, but we do a complete overhaul of the model that we're using to evaluate and to treat severe hypertension in Kansas, here's your new model. So again, it looks very similar to the way that we set up the postpartum model. We did that on purpose so that you all could watch the workflow. That's a pretty common term in medical societies now, workflow versus algorithm. Whatever. I'm going to use algorithm. But left side to right side story about you've got to identify it first. We've got to have standardized protocols.
Estamos platicando.
And then we definitely need to elevate care if that patient requires inpatient transfer, if she's already in that higher level of care. What's the lactation initiation? What specialty services does she need? And what are her DOH needs? If she's discharged, what's the follow-up? If on the left-hand side, we treated it at that facility, didn't require elevated care, but then what's the plan for her outpatient follow-up? Very specific protocols around that as well. How do we involve navigation, case management, referral to appropriate sources? Then there's all of your fourth trimester pieces on that long column about halfway through. What are her other needs or her coexisting needs? And the loop closure that she follows up postpartum. Knowing that hypertensive disorders do not happen just in the immediate postpartum period, right? This also corresponds to antepartum or pregnancy care. Next slide. All of you, or most of you, should have seen the severe hypertension in Kansas facts sheet. If you do not have a copy and you'd like one, please reach out to Tiffany maybe on the chat. Tiffany, if you want to open that up, that's fine. Or certainly you can email Carrie or I, and we're happy to send a copy of this to you. We've encouraged all of our sites that we've talked to share this with their staff, their providers, their administration, their QI folks, so that they know what exciting work is happening across the state. Also, as you're thinking about enrollment, I think we did a much better job with this bundle about being specific about expectations from hospitals that are enrolled. The fact that we're going to include non-birthing facilities. So our birthing facilities and our non-birthing facilities are both invited and encouraged to participate. And then we're going to walk through this fact sheet a little bit more, but it really is the timeline of this QI work so that you know exactly where we're headed. Next slide. So here we are, the beginning. Sure enough, Q1 2025, we launched, sent out fact sheets and enrollment packets to all of the previous enrolled sites and those who would express that they want to be enrolled in the next bundle. Here we are, and we've begun to receive enrollments. They're coming in. Awesome. So we are in Q1. We will then, of course, progress through this half circle, Q2, Q3 of this year, and 4, and then what happens as we go through the end of this year and into next. Please focus on the fact that this is a fairly quick bundle. We will not be lasting as long as first trimester. The intent is that we really can target and change outcomes quickly with this bundle if we can follow this train of reasoning and timeline. So enrollment's time limited. You'll see that in a second, but we're going to start rolling pretty quick once we hit Q2 on the pieces of this puzzle, which will improve maternal outcomes as quickly as possible. Next slide. This is the same thing as you saw with our new model of care. Again, we want to make sure everybody's on the same page about what this means. Like, if we enroll, what does it really mean? It simply means identification of hypertension. It seems basic, but we know across the state that that's not consistent, and we need to fix that. Severe hypertension protocols, what qualifies as best practice and what doesn't, and then screening for the things that many of you have already been doing, just continuing the same. And then again, what happens with elevated care or not, and then making sure that we close that loop. Next slide. Gary and Jill and I spent many hours making sure that we had everything lined up as we launched this bad boy. And really, this is just a reminder for you all to know that there will be very specific things each quarter that we focus on. We've got guest speakers lined up across the state that are experts in this field. We have goals to reach out to communities. We have a CUF project launch. We are excited for all of the resources in Kansas that we already have, and adding some new options is pretty exciting as well. You'll also note, as we had talked about, that our pumping protocol and initiation of lactation as part of the sequelae has to be included. We know that our neonatal outcomes have to improve. We also know that breastfeeding outcomes oftentimes diminish in this time of crisis because it's forgotten in the middle of hypertensive treatment, and it shouldn't be. So we will combine pediatric and maternal health initiatives in exciting time towards the middle to the end of 2025, and follow it through. Next slide. So again, just a reminder of some timelines. So most of you, if not all of you, have already received your enrollment packet for this bundle. If you did not, please reach out to us right away. We will send you an enrollment packet. It's very simple. It has everything we're talking about in it right now. If you've already been a 4th trimester site, it's even easier. You check the box that you were a previous site, sign the document, get it back to us, and we're rolling. If you are a non-birthing facility, we are thrilled to have you too. I'm going to ask you to reach out to Carrie and email Carrie. I know everybody knows it. You want to type it in the chat for me. Reach out to Carrie and make sure that she'll connect to you, give you information about how to get enrolled and get started. And then we'll get you looped in. For everyone, birthing and non-birthing facilities, we must have enrollment completed by February 10th. That is not a long time from now. So I know many of you are holding on to your packets, just waiting until the 9th to send them to me. And I know they will come, and I have been you, so I understand. But as soon as you can get those to us and we can get data collection started, it will be It's pretty fast and furious, and not in a bad way, guys. The data collection I'll talk about in a second is not that scary. We do want our baseline data for those of you that enrolled done by the end of March. So you've got plenty of time to get it in. Next slide. So what's your homework from us? Your homework is, this is the video we talked about. This is the AIM video about this bundle. Pretty succinct, very helpful information about severe hypertensive disorder pregnancy and the safety and QI processes of the national bundle. We then ask you to review your hypertensive protocol if you have one, compare it to some things that you're hearing and seeing, and get ready for action. You may already be 90% through this bundle. In fact, we suspect many of you are, but we're going to make sure everybody's linked in and we have all those resources at your disposal. And then in all caps, bolded, exclamation point, enroll. We want to have everybody enrolled. Next slide. Once you do so, don't be overwhelmed by this slide. This is just a gentle reminder of what I needed to tell you. Once you've enrolled, you'll receive an email from myself or from Carrie that tells you about next steps. On the left-hand side, where it says facility and reporting period, that little kind of darker edged screenshot, you will get a link to REDCap. You will get on REDCap and feed through the data submission. It isn't hard, but again, because we've been you, we created a cheat sheet. So on the bottom middle there with highlighted blue and yellow, each of the questions that you'll get in REDCap has the question, has where the data should come through, and has special notes or cheat sheet material about how to find that data or when it should be put in. Okay, so there you've got it. You've got your cheat sheet, piece of cake. And that cheat sheet has several pages in it with all the questions, but also has some important graphics for you to pay attention to. For example, you're going to be asked if you have a hypertensive protocol in place, and you go, well, I think so, but does it qualify? The answer is, and you'll see it on the right-hand side where it says hypertensive emergency checklist. That's one example of the protocols that we will take. In the cheat sheet, it talks about what the protocols are that we accept. There's an example of one. Okay. Another one is right there on the next page, right? So you'll see the appendix B, I think it is, suspected preeclampsia algorithm. See, they're speaking my language. And that's another accepted algorithm or workflow or protocol. So they meet those, great. If you're not sure, hit no on your baseline data and let's work through it and we'll make sure that you're up to speed. It's just baseline data, okay? So top, middle, also included in the cheat sheet, pulls out your ICD-10 codes that you need, talks about what qualifies as a morbidity. We tried to give you as much as we could so that it would not feel overwhelming or daunting to put the data in. But we are at your disposal. We are happy to help. We do not want the data to be a barrier to your enrollment, and we will help you work through the pieces of this if that becomes a challenge. Next slide. 12:32. We did it. Got it. Hey, we want to take time before we let you guys go. We're going to give you some time back today. We know it's crazy across the state and we know how hard you're working. We would like to, we're going to open up for questions. Pop on your mic and or in the chat. We're happy to answer what we can. If not, we'll follow up with you. If you just want to email us, that's fine too. And then a plug for next month's Learning Forum on the 25th at noon in February. That link right there, Tiffany created for you, helps you register so that you get the reminder and the link. And excited to meet back next month, where we will dive deeper into the specific diagnoses of hypertension. Again, it seems elementary. It's not. There are many different incorrect diagnoses and protocols happening across the state. So we're going to go basics and go from there. Let's open it up to questions.
There were a couple of questions in the chat. I'm just scrolling back up. If you have a question you want to ask out loud, you're welcome to jump on. There There was one question, are there plans to address babies leaving the NICU to have their appointments already set up as well through the hospitals prior to discharge?
I heard part of that, Tiffany. Can you repeat it? I can't find it.
Are there plans to address babies leaving the NICU to have their appointments already set up as well through the hospitals prior to discharge?
I would love to have that as part of this initiative. It's not called out specifically, but just like in our previous one, if we find that that is a problem, and I'm going to guess whoever asked that believes it is, then we definitely should attack that. So keep that in mind and nudge us about thoughts and concerns, or perhaps what's happening in our tertiary care center NICUs. My phone is blowing up with people emailing, so I know that a lot of you are asking questions. You too, Carrie. That's how I communicate too. I love it. I have 4 different screens and a phone. I know I'm not alone. We will respond to your emails. I also just got a question from somebody regarding the cheat sheet, and can it go out ahead of time because the QI is asking about that. Meaning the hospital wants to enroll, but their QI people or their legal team wants to see what the questions are that are going to be asked. We will share that information with you. Absolutely. Any other questions before we let you guys go and enjoy the rest of your noon hour? All right, we're going to let you go. We will be announcing and reminding everybody about our in-person that's coming up this spring. Those of you that were part of the first trimester initiative, we will be awarding your official certificate. It's like an elementary school, right? We will be celebrating all of you in person when we see you in April, and look forward to talking again in February, if not before. Thanks, everybody. Appreciate your hard work. Have a great day.
We had 70 attendees, you guys. That was exciting.
Will you remove